Welcome to our monthly NAMI Eastside's monthly forum for mental health education. We're sponsored by EvergreenHealth. My name is Edie Myers-Power. I'm the program manager at NAMI Eastside. And tonight, I'm pleased to introduce tonight's speaker, Carrie Armour from NeuroStim. She's going to be educating us tonight about transcranial magnetic stimulation, which is a medication-free treatment for depression that NeuroStim offers as part of their services. So with that, Carrie, I'll let you go ahead and take it away.
Great. Thank you so much, Edie. You've been such a pleasure to work with. So I really appreciate this honor to be here and share with everyone about TMS. So the title of the presentation is Shining Light into Dark Places. As we know, the pulse of mental health is incredibly robust right now, right? We are in a place where we need to have more than one solution when it comes to treating depression and other diagnoses. So thanks again for having me. So, whoopsie, that went fast there. Again, my name is Carrie and I'm the Director of Communications and I do work for NeuroStim. I have 20 years of healthcare experience. I've been a clinician in the physical therapy space. I've done some marketing. I've been a business owner as a franchisee. But most of my career, I've worked with the geriatric population, with fall reduction programs, and was in a clinical space there. I did a lot of work with folks that needed modalities to adjunct their care. So I would work with people a lot of the time, and did electrical stimulation to help people after a stroke, or I would do, ultrasound to help people. I did wound care. So I was used to working with modalities to help patients meet their goals and objectives in the physical therapy space. So after being in physical therapy for almost 20 years and being in the healthcare ecosystem, I heard about neuromodulation, which is TMS, transcranial magnetic stimulation. And I thought to myself, why don't I know about this? It's kind of crazy that we don't know about this. It's not new. So I know that when you guys walk away today, you're going to learn something about this amazing technology. So for the purpose of this presentation, we're going to discuss depression, okay? We're going to kind of discuss treating depression, some of the conventional and unconventional ways of treating depression. Ultimately, what makes the TMS right for a patient, so kind of the implications or indications to treat. Okay, the costs, it's covered, whether it's cost by insurance and then some other options there, and then obviously the time commitment. So I really love this slide because this really showcases it illustrates the understanding that, being depressed and having a mood disorder is not our fault. Okay. It is a physiological presentation that we can see that happens in the brain. If you look at a depressed brain and you look at a normal brain, the depressed brain has hypoactive areas of the brain and or hypo or non-active areas in the brain. Okay. So it means that everything is dampened, right? If we're not operating on all four cylinders, so to speak, of course it's going to affect the way that we feel, how we act, what our motivations are, how we perceive the world. What we know is that, depression is also a massive societal burden, right? We're dealing with comorbidities, like depression shows up differently for everyone. And there's a lot of subsets and things like that. So depression, again, just looks different for everyone. And so there is no one person that has the same, lit up brain, so to speak, than anyone else. So by the time patients see us, okay, they have tried some kind of psychotherapy, depression counseling, medication management. And what we know is that 51% of patients treated for depression do not respond to the first round of medication. And that is incredibly frustrating for the patients, the providers, the whole entire mental health ecosystem, because it's basically like, hurry up and wait, right? Maybe this will work for you. Maybe this will work for you. Let's give it 3 weeks, see if this will work for you. Oh, and by the way, maybe you can just try another medication to layer on to the other pharmacological agent that you have going on. So it's frustrating for us in the TMS community because we're treating something at the focality of what's going on at the source, right? We're treating the problem at the source. So we know that drugs can be highly effective. And it says here that 49% of the treated population will benefit. However, it's actually a little lower than that because we have to consider the placebo control group. So that'll be illustrated here. Sorry, there we go. That's why I like this slide. So like I said, it said 49%. So what we're really looking at is 27.5%. Okay. So after the third medication that people attempt to use for depression, the efficacy goes down to less than 7% that any of these meds will work for these people, right? These people meaning me. I've been I've been diagnosed with depression since in my 20s. I've been on medications since my 20s. And so I can speak from a patient perspective, and I'll tell you guys a little bit more about that after we go through the slides. So what this slide shows is that when you're looking at depression or TMS treatment, you can see that 72% of people respond to TMS treatment. And then almost 50% of those people are considered to be in full remission after 12 months. So the durability of TMS is actually quite significant when you're looking at other unconventional options such as ketamine. Again, I'm not saying it shouldn't be on the shelf and on the table as a treatment option, because who are we to judge people trying what they want to try? I think it's just we're looking at this modality, and it's sometimes more effective because people don't want to go through the trip or they don't want to get ill. It's just great that we're actually talking about other modalities and other treatment options other than medications. So this slide just illustrates the different side effects that can be compared when we're looking at TMS compared to ECT and compared to ultimately drug therapy. So you'll see in the white, you have some of these side effects that can occur with medications. In the yellow, you can see some of the side effects that happen with ECT. And with the green, we're simply trying to illustrate that about 20% of our patients will complain of superficial kind of scalp tenderness. But again, this is something that you acclimate to and you accommodate to, just like with any stimuli that we can experience on our skin. So yeah, and I'll talk a little bit more about kind of what the treatment feels like and what it looks like moving forward. So this slide is just trying to illustrate here how magnets are not new in Western medicine and in medicine in general. We've been using them since the 1800s. But it wasn't until 1985 that we developed the first transcranial magnetic stimulator. So a gentleman named Tony Barker developed the first magnetic stimulator. but it wasn't until 2008 that TMS became FDA approved. And then it wasn't until 2013 that insurance started paying for it. So it is kind of slow as we develop, research, and continual research is happening in the TMS community as we speak. And I can talk more about that as well. So we're going to talk about neurotransmitters and neuroplasticity. So a little bit about the science about what actually happens with this treatment. So this is just giving us an idea of kind of a timeline here that has happened throughout time and kind of where we've been, where we're at, and where we're going with TMS. So you can see that there's quite a pathway here that ultimately, I'll just kind of, to be respectful of time, I'll hit the key time factors here, right? That we understood that the Faraday's law established that there was, number one, that nerves actually carry an electrical current, and that we understood that it could be manipulated with magnetic fields and electrical currents. 1985, the first TMS machine is created. We have the first TMS treatment. 1987, TMS safety establishes some safety guidelines. The 1990s, we confirmed safety and effectiveness of TMS. In 2003, Canada approves TMS therapy. 2008, like I said, the FDA approval occurs for MDD, and that's major depressive disorder. Okay. So in 2010, the National Institute of Health confirms effectiveness of TMS. 2013, insurance starts to pay for this. 2018, Neurostim, TMS Centers of Washington, we open up our first clinic in Lakewood. 2019, we develop what's called the Theta Burst protocol. And what's great about this is that it shortens the treatment time from 3 to 5 minutes, because it was originally about 17 to 19 minutes. Okay. 2020, FDA approval for OCD. 2022, Stanford creates a 5-day accelerated treatment protocol, also known as the SAINT protocol or the SNT protocol. So and I'll explain this a little bit more when we look at different treatment options. 2023, Neurostim, we open up our 10th clinic in Spokane Valley. Right now, there's a lot of research going into how neuromodulation can help people with all kinds of diagnoses. I'm talking about dementia, stroke, Alzheimer's, all kinds of neurological disorders. The thing here that I want everyone to understand is that TMS can treat anything that occurs really as a result of something that's going on in the prefrontal cortex of the brain. All right. Without getting into too much neuroanatomy here, that's basically how this treatment can be leveraged in the future. We use a machine from the manufacturer called MagVenture, and that has just been FDA approved for a pain management perspective. So mark my words, neuromodulation is going to be on the table for a lot of different things. So I'm going to go ahead and use my hands a little bit, because I like to use my hands to help understand kind of what's going on with this treatment. All right. So imagine our brain here. Okay. And we've got this area of our brain that's not active enough. All right. And should it be active, a little bit more active, it might affect our mood disorder. All right. Well, we know this to be true. All right. So we've got this neuron, this brain cell, okay? And here it is with an electric charge potential, and it's hanging out in our brain. And we utilize the magnetic coil up to the part of the brain that needs the stimulation. And by doing so, we're using these magnetic pulses to activate the neurons to get to that part of the brain. So by doing so, we're literally turning up the activation on a cortical level. All right. So depending on what we're treating depends on what the symptom response you'll find. Meaning, if someone is depressed, we would need to excite some of the other parts of the brain. If someone has hypervigilance, right, with PTSD, that means their amygdala is hyperactive, and we need to tone that part of the brain down. So this will kind of illustrate that a little bit more clearly. So again, I want you guys to think about this blue area as an area that's maybe too underactive, right? And these orange and red areas are hyperactive. They're too active. And so what happens is we've got an issue where the coaches are not in charge of the players. Okay. You can kind of look at it like that, right? Where there's disruption in the hierarchy of how things are going on in the brain because there's not the balance, there's not that homeostasis. So I like this slide because ultimately it shows the balance that we're trying to achieve so we can regulate our emotions and our mood based off of the activity that's going on in the brain. So this just illustrates kind of, what you can see as a result of treatment, depending on the diagnosis, right? So you can see increased dopamine, and so therefore, hence increased joy, stable mood, emotion regulation. People become a little more rational. Okay, again, this is part of the brain in the executive function part of the brain. It's kind of like our governor of our emotions and our mood. All right. So when the governor is working well, it can kind of help with, reeling in some of that order is really what it is. So you can start to see increased attention and focus. It is utilized with some people as a cognitive enhancement. Again, we do, treat people with cognitive issues as it relates to some of their secondary diagnosis, whether it's TBI or CVA, strokes, or total traumatic brain injuries. Fun fact, didn't know this, but it's public knowledge. We had nothing to do with it, so it's not a HIPAA thing. But just as a fun fact, the Seattle Seahawks, when we had the Legion of Boom, right, they were all on TMS. So they were, some people would argue that maybe their executive function was a little bit better, but anyway, I digress. So some other things that you might see is just truly more resilience, right? Ability to cope with stress. So adversity and stress, overall better regulation of perception and the situation of what's going on. So you see a functional ability to see the future. That is literally what we're all about, is showcasing that there is in fact hope when a lot of people have lost hope. You see less social isolation. Some other secondary gains that are unexpected are increased quality of sleep, increased energy, increased self-awareness and organization, and increased empathy. So a lot of times what the mental health providers are telling us is that once the patient has their physiology straightened out, then they can really show up to do the work because they have more self-awareness, because they have more ability to be compliant with with the work that is required of them to have those great outcomes with our mental health providers. Some things that you might see in terms of decreased is lethargy or decreased inertia, ability to get out of bed, decreased anger, blame, catastrophizing, perseveration, impulsivity, suicide ideation, and tremor. So what happens in this mysterious chair? So basically, it's a chair. You can elevate your feet. You put on this sexy little cap, okay, and we have markings on the cap, and we measure it by bony prominences, according to your skull, right, your head, and your anatomical significance. We use what's called the beam method, so you could look that up. So we know exactly where we're targeting. We have a little cervical pillow that just kind of gets your head comfortable there, and depending on the diagnosis, depends on where we treat. So usually the treatments are anywhere from 5 to 20 minutes per treatment session. It is in an office setting, but all of our clinics are incredibly thoughtfully, intentionally designed and decorated, where everything is light and bright, where it doesn't feel, sterile. These clinics are really beautiful, where they have, water features and, soundscapes going on in the lobbies and such. So, like I said, it is a time commitment, okay? But we have to look at the issue here as when we're looking at risks and benefits, where people have been dealing with treatment-resistant depression for 20 years. Maybe they've been, they've tried all medications, they've tried talk therapy, they've tried these different things. So truly, we just want people to know what's on the menu, right? So yeah, I mean, it's really quite easy. You can drive yourself to your appointment. It's outpatient. So it's like a Monday through Friday scenario where you get your time slot, and that's just your slot. So we have 10 clinics in the state of Washington right now. We're opening up Tri-Cities and Vancouver very shortly, probably within the next 60 to 90 days. We are growing for a reason, and it's because we have been able to help thousands of patients, and we take great pride in the fact that we see great results. Now, I will say that it burdens us that when, people don't respond, because it is essentially 75% response. Now, there are some studies that say 80% response, because people continue to get results after their last treatment, because the neuroplasticity continues to occur within the brain after their last treatment session. However, my COO said it the best way. He said, hey, if I can throw a life preserver, I'm on a sinking ship, and I can throw a life preserver out, and 3 out of 4 people are going to be able to grasp that life preserver, I'm going to throw it out there, right? This is better than, we're just so glad that we can help the people that do respond. So this is just, talking about where we're at when it comes to, essentially we're doing more TMS than most of our competitors are combined. Yeah, I mean, we're just obviously proud that we've figured out a way to really, scale our outcomes with our provider outreach, with the relationships that we have in the community, with our amazing relationship we have with NAMI. The more and more people talk about options, the better it is for people and stigma in general. So I love this slide as well. This just kind of illustrates some of our medical team. Dr. Jonathan Downer, I know it's kind of funny that his last name is Downer when we're working in depression here. I try to use comedy every once in a while when we can, right? But Dr. Jonathan Downer is a remarkable neuroscientist, and he is our chief medical advisor. We are so lucky that we can call ourselves a Stanford educated organization because we get continued education from Dr. Jonathan Downer and his staff throughout the year. In fact, we're going to have our annual in-service this Friday in Federal Way at our Federal Way clinic, and he's going to be there, and he's a keynote speaker at all, TMS conventions. Just look him up on YouTube, and you'll see kind of what a renowned neuroscientist this gentleman is. He is actually responsible for getting some of these protocols FDA approved. And in fact, he's even coming out with a new coil that has a camera on it to help with patient safety and efficacy. So, for example, I could be in Europe and I could be giving a treatment to Edie, and I could be seeing the treatment with a camera, and it would be marked, locked and loaded, basically. So there's no room for error. This looks at some of kind of the industry standards for billing and insurance purposes. We have to combat a lot of things with this TMS. Number one, that it's too expensive and we can't afford it. Well, insurance pays for this treatment. So that is something that we have to educate people about, is that yes, if you were going to pay for it out of pocket, that it could be anywhere from $6,000 to $8,000, okay? Depending on, your situation. I think the big takeaway here is that we will never, ever let a monetary barrier get in the way of someone trying to seek treatment. We do a considerable amount of pro bono. And again, it just depends on what the patient's insurance is. We accept everything. We accept Medicaid, we accept Medicare, VA, TRICARE, you name it. So this just kind of talks about some of the requirements, right? So essentially, if a patient has tried 2 to 4 medications and or some kind of talk therapy in the past, you're likely going to get this covered for by insurance. All right. The big contraindications is that you don't have any metal that's not MRI safe from the collarbone up. So if someone has a pacemaker, that's usually a hard no, unfortunately. However, if the metal is MRI safe, from the shoulder up, then you're good to go. Patients have treatment with their nose rings and ear piercings all the time. Dental work is fine. Some people have stents or mesh metal stents, like in their cervical spine for blood flow, things like that. Again, we have treated people with some of these things, but again, it's if it's not MRI safe, it's usually not safe to do the treatment. Now, let's talk about some of these other, precautions. We know that chemical dependency, what came first, the chicken or the egg, right? When we're talking about self-medicating and mental health. So that is not a contraindication. It just means that we want to understand the patient's history, so we know how to properly treat them and how it's ultimately going to affect their outcome, because sometimes it can take longer for people who say smoke marijuana every day, because those neurons might be dampened a little bit, and so it might just take longer to get that response. Let's see. This just is, giving you an idea. In a matter of 2 months, you could be done with this thing, right? And ultimately, change the way that you perceive your world and the way that you take in the world. And, you look at a pill bottle, okay, and, it's like, how many pills, pills do you have to take, before, it's just kind of trying to help you understand that, we take pills all the time, and ultimately within 2 months, things could be a little different for you. We're pretty proud of the fact that we got Provider of the Year with NAMI. And, we're really proud of that. We're going to be doing the NAMI walk again this year. Of course, we're going to be sponsoring it. We're actually going to be starting a NAMI Connection Recovery Support Group. And we'll probably launch that in April or beginning of May. My colleague and I have been certified. I don't know if you can't see that, right? Okay, well, nope. I took the certification process to become a facilitator for NAMI because through NAMI for TMS, because there are a lot of people who are inquiring about it, and we see our role as market leaders to answer the call. A lot of people get well with TMS, and then they don't feel connected to another support group. So this is why we're leveraging NAMI support systems, so they can feel like they have more of a community after treatment. And then also there's a lot of misnomers about TMS, what it is and what it isn't. So that's why we're launching that support group. That is all I have. I know that this was a considerable amount of information coming your way. I am happy to answer any and all questions that people may have. Maybe I could just not share my screen anymore, Edie, or what do you think would be appropriate? Yeah, okay. So exit, let's see.
I got a question, Kari.
Yeah.
I wanted to know it said each treatment varies from 5 to up to 20 minutes. Why is there such a discrepancy? Why is there that?
Great question.
Short and long.
Right. Great question. So, for example, and I'm happy to be transparent about my treatment journey as well. So, but speaking universally, if you treat 5 minutes on the right, that's said to be help with anxiety. If you treat on the left, that's supposed to help with depression. So we always like to treat both, right? In some cases, people truly just have anxiety, and that's all we're trying to target is the one side of the brain. So, but we know that anxiety and depression can mirror symptoms. So we want to get at it at both levels. For me, when I did treatment, I actually noticed that my anxiety kind of creeped up a little bit towards the middle of treatment because my depression wasn't combating with it anymore, right? So it presented like my anxiety was a little higher, although really what was happening is my depression was diminishing. So then it dampened my anxiety. So that's just something that can happen. Again, we treat everything, right? Anything from ADHD, autism, PTSD, bipolar, tinnitus, eating disorders. However, in order to get it covered by insurance, and other things, OCD, but in order to get it covered by insurance, that primary diagnosis has to be MDD or OCD. Now, we fortunately, unfortunately, understand how to navigate this healthcare system thing and insurance thing. So we will, we know that people with PTSD are not happy people, right? So the mental health providers or the primary care providers or their psychiatrists are able to make sure that that primary diagnosis is MDD to get them coverage. You asked about why 5 to 20 minutes. Let's say someone has suicide ideation, they have OCD, impulsivity, something like that. We might do a medial treatment right here that's maybe only, 6 minutes. So just depending on what the patient needs is really how we try to customize it.
And then another question I had, thank you again for clarifying, is how do you get the statistics of people feeling like it's helped them or that it's not? Is there some like diagnosis of, or is it just how they feel and they're just telling?
Well, we know that by activating parts of the brain with the neurons, right? Activating the neurons, that lights up part of the brain. And so people who feel good and don't have diagnoses have brains that are lit up more, right?
Yeah.
Right. However, to your point, we use what's called the PHQ-9. So that is based off of, how the patient is feeling, how, it's kind of a questionnaire of sorts. And we always want to treat to remission. So if our patients are getting better and better and better at 36 treatments, if they feel like they want to go a little bit more, then we always treat to remission. For me, I needed 47 treatments. I don't know why, but my brain was just like that. So now I am on what's called a maintenance program, right? So, and my husband likes to remind me, he likes to say, do you need your TMS when I'm getting a little more volatile, maybe a little more emotional, maybe a little bit more, impatient, you get to know people in your life. And what we find is people in your life start to notice the differences before even you do. There's a significant shift that happens when, I can stop sharing this. I'm so sorry, you guys. Okay. There is a significant shift that happens with our patients when they stop coming in because their doctor told them to, and when they start coming in for themselves, we see folks who, are not hygienic. They haven't taken showers, and they're walking down the hall and, body language, how they present themselves. And then, we start to see them wave goodbye and see us looking in the eye, and we see, I get emotional because it was like a switch for me. And I had been on so many meds, and, I can tell you more about my story as well, but I had horrible postpartum depression. My father died, and we know that grief actually has a huge role to play on our cortical level, on a neurological level, and what that does to our neurons. And so it was like a lot going on. And my husband was like, okay, I don't know who you are. This isn't working for me. I really needed to seek something out. So when I found this treatment as an option, I mean, I ran marathons, I lifted, I had a physical therapy background. I could not exercise this thing away, right? I could not exercise this thing away. And I found this treatment, and it really did change my life. So I have no problem being an advocate for this company. Sorry, I digress. I tend to do that. Christy, you have your hand up. Can I answer a question for you?
Oh, yeah. I'm not sure how to put my hand down. Anyway, I'm just having issues. My question is I had TMS several years ago.
Okay.
And actually this couldn't be a better time for this presentation. I've been thinking about doing it my depression has been just terrible, awful for a long time. But I was thinking last week, you know, I've called your clinic several times and I have the paperwork, but I haven't filled it out or anything. But I guess my question for you is who decides at your clinic, who figures out where to put the you know, the coils. It's been so long since I had it done. And I mean, I think it helped me sort of, but then I started drinking again. So I don't know.
I get it. I get it.
But it's sort of strange because I started feeling better. And then because of that, I thought that I could manage my drinking. It's just, you know, good old addiction and mental health. But anyway, that was then. But I'm wondering who figures out where to put the coils. And then at your clinic, do you have the same person each day that you come in sit with you, and is it monitored while you're having it done?
Yes, great question. And Christy, thanks for putting yourself out there and being vulnerable. Okay, I really appreciate that. Yes, so it absolutely is consistent. So the psychiatrist or the physician's assistant and or the you know, they oversee the treatment initially, and then you have a technician who is applying the treatment every day. So it's you know, like I said, you have that cap on, and then the coil, it's kind of like there's like a little marking on your cap, and you know exactly where to put that. And the error rate is such that we know that by targeting this area, even if we tilt the coil this way a little bit and or this way a little bit and or this way a little bit, that we're going to get at that area of the brain that needs it. And so but these guys, they go through 8 weeks of training before they're allowed to do any treatment alone. All right. We put them through rigorous training, overseen by the psychiatrist and our clinical staff. So, and they all have medical backgrounds and, or, you know, organic chemistry degrees and like what have you. So we hire the best, and we're incredibly picky. And because we rely on them, you know, this is a journey, right? It's a journey. You're going in every day, and you need to make sure that you feel like you're connecting with the person that's connecting you to this modality, right? And so that is a really integral part of that. You know, we also think that people start to feel a little better because they're accountable to this thing, right? And they come in every day and they start to develop a relationship, right? And that, I think, has a big part to do with the therapeutic journey as well. So yeah, and just to give you another idea, to kind of unveil the mystery of the treatment, we put the cap on. So it's called your MT, all right, to figure out the dose that you need to stimulate your neurons in your brain. They put the cap on, right, and they put the coil on. You put your finger up, okay, and you know how the brain is vice versa. Okay, well, they put it on the opposite side and they activate, and your finger will go like this. Boop, boop, boop. And then they wait until, they wait, you know the drill, right? So they wait until they can hardly see any movement at all. And so that's when we know that that's the amount of stimuli that it's going to take for that neuron to get excited. All right. And so we do rechecks with the psychiatrists to make sure that you're still getting an accurate dose, because the therapeutic dose, because different things can affect that excitability, like caffeine, like sleep, like medications, like, you know, things like that. So we just want to make sure that we're accurately, you're accurately getting what you need to have the most expeditious outcome. I hope that answered your question.
Thank you. Yes,
Okay.
yes, it did. Thank you so much.
Yeah. And Christy, I think I can lower your hand for you, so don't worry about that.
Oh, thank you.
Yeah.
Tara, did you have a question? Oh, you're muted.
My questions are in the chat.
So, let's look at the chat. Yes, 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 and yes. So what we actually have treated people as a secondary off-label treatment for alcohol cessation. I actually just did a presentation yesterday with Treatment and Associates there in Bellevue about this exact thing with their case manager. Now, for insurance purposes, I think they make you wait 12 months, but it's not for every insurance provider. A previous concussion would be okay. In fact, that would be an off-label treatment. So that would be fine.
So, I mean, I was diagnosed with a concussion this summer. So
Okay.
and then ended up having vertigo and then all my symptoms are
Okay.
gone. But I don't know, if concussion is.
Yeah, that's a great question. So did you ever, if you saw a neurologist, we would probably you don't need a referral for treatment. But we would, if you felt better about talking to your, primary care doctor and or your neurologist to clear you, that'd be fine. But we do an extensive consultation where we would know where you would need to be at your treatment. Yeah. But that is not contraindicated. Those two things are not contraindications to treatment.
Oh, that's what it said on that one screen.
So if you have, that's just another precaution that we want to know about, right?
Okay.
So something we want to know more about in terms of the patient's histrionics. Yeah. And I'm sorry. So to clarify, the big problem, if someone has active seizures or they're on seizure medication, that is something that we would need to look a little bit more deeply into. And or if someone has like metal that's not MRI safe. Okay, so those are the only two things that are, we really look at.
And you encourage people to continue on their antidepressants while they're going through the treatment?
Absolutely. Absolutely. We do not want to change those variables because we want to know what's working and what's not, right? Some people are able to titrate off their medications completely. Some people are able to go to lower doses. Yeah, I mean, this is real. For me, I was able to titrate. I was on all kinds of things. I tried every family, SNRI, SRI, you name it. And I just use trazodone, PRN as needed for sleep now. Yeah, so.
Thank you.
You bet, you bet. I love your glasses, by the way. Those are so cute.
Carrie, I have a question mostly out of curiosity, because I've never looked into this before, but I actually have titanium in my shoulder. Is that MRI safe, or do you happen to know off the top of your head?
Titanium, I think, is actually cleared. Yeah, I think that is. Cool. I will get back to you and I'll email you, but I think that's good. Yep.
Very cool.
They do that on purpose. Yep. Margaret.
Hi again. I had a question. Can you go into more detail on that Stanford study?
Which one? There's lots of Stanford
studies. I had heard about it. They were asking for people to participate in a study. This was maybe a year and a half ago.
Okay.
Is
Was
that
it that most recent one on the timeline? I think there was a really recent one that they cleared it for a couple
Yeah.
things, maybe.
Yes,
Yeah.
they did. And we know everyone that's involved with these studies. So we love to nerd out and talk about this. Basically, just to go back a little bit though, there's what's called a SAINT or an accelerated treatment protocol. And that's you're getting in 1 week what you'd be getting in 6 weeks. Okay. So you'd be getting 5 to 10 treatments a day for 5 days, right? An entire week, but you're expedited, right? And unfortunately, that is not covered by insurance because heaven forbid we have people get better sooner, right? Anyway, I digress, but that is not covered by insurance. But some people decide to go that route. We have great spacious rooms where people bring in their laptop, they work from home and they do their treatment, they bring their child in. We set it up with snacks and, Netflix and nice, beautiful, spacious rooms and couches for you to relax. So I have a lot of, providers actually that, do this route, high stressful, high performing anxiety patients, a lot of times will go this route. And that's a private pay scenario. But we work on a tiered system. So, we work with people.
So their findings is that having 5 treatments a day or whatever it was is as effective as doing it slowly over time.
Yeah. So the FDA, I think, didn't feel comfortable with however, what we find is in some studies, we actually find it actually even more efficacious. So, it's there. I have loads of research, Margaret, if you want more information on Stanford, on what research we have to leverage. And if you have specific information about a specific diagnosis, we're happy to leverage that for you as well. And I don't know, Edie, if you can give my email out, is that okay? Or
yeah, I'm happy to. I was just going to ask you if you were comfortable with me giving. I can even just drop it in the chat right here for everybody.
100%. In fact, please do, and I'm happy to answer any questions and get back to you with a more comprehensive answer.
Awesome. I will just drop it in the chat right here so anyone can use it to ask you more questions. We do have some time still for more questions also here in the.
So the only side sensitivity, I've heard that you might get like headaches.
Yeah. So basically 20% of our patients will complain of a mild headache. But again, this is something that you kind of acclimate to. Some people we'll just take a Tylenol or an ibuprofen, what have you. Again, that's a personal preference. And some people literally feel like it's nothing, right? Again, depending on your treatment, pain is subjective. It's a very tolerable treatment, but it feels like little rubber bands. Like it kind of feels like tiny little rubber bands kind of flicking at your head, but it's a tolerable experience. So like the treatment on the left sometimes can feel a little more spicy. But again, it's something that you get used to and you acclimate to. So 20% of our patients will start to see a difference in a week. Those are our early responders. Okay. But it's more likely that the small wins that we're celebrating with our patients are occurring at around 15 to 23 treatments. Patients will say, that's kind of that sweet spot where patients will say, oh, I was in traffic and I was late and I I didn't freak out, or, oh, I really handled that situation well with my colleague or my family member. And wow, I really paused for a moment and I didn't react, or I didn't yell, or I didn't this, or I didn't, I notice it with my husband. I don't let him get me riled up as much anymore. I'm not as needy. I feel more confident. I feel like I can be present in the moment and I can let things go. Like I don't go down the rabbit hole and perseverate on issues that I seem to not be able to let go of when I was in the thick of it.
What is your maintenance? Is it yearly, like just one time, or do you?
Yeah, that's fair.
Don't mind me asking.
Yeah, no, that's fine. I'm a total open book. I truly am. In fact, on my LinkedIn, I have pictures of me getting treatment, and I don't care. I'm a total open book. My maintenance treatment is like every 6 months. I go in for like 3 times a week. Again, it's different for everyone. And everyone's wired differently. 30% of our patients will require a tune-up, right? But we look at it like exercise, not surgery. So, I'm okay with that. And it's like, if that's going to get me right, well, then so be it, and that's just what I've come to understand throughout, being on meds for 20 years. It's like, I'm okay with that, and I have to say that, this is a really interesting time in psychiatry, because we're going to a place where, it's kind of like psychiatry, like 1.0, where we had this Freudian era, right? Where you had the ego and the id and your place in your family and your position and all of this, and that's who you are, to psychiatry 2.0, where we have pharmacological interventions, and we now have this chemical imbalance, right? The narrative is still like, something's wrong with me, something is lacking with me, right? And now we're in psychiatry 3.0, where we're looking at neuromodulation. And this is what this is where we can simply recalibrate the brain, because it's recalibratable. It's not going to change your personality. In fact, it's not going to hurt you. It's only going to help you. So it's good to know, right? That, if you broke your leg, you'd wear a cast. And this is what we used to say about meds, right? But now we're understanding that these side effects we don't have to deal with these side effects. And that if it's not working, we can try something else.
Thank you.
So Carrie, I don't know if you can hear me.
I can't.
It's Kim. I came in a little bit late, so I'm not sure if you covered this before I got here. Is this like a one-shot deal? Or is it, I mean, you're on maintenance, or I get that part, but is it like you get it, you go through this treatment and your depression is gone? Or is it just something that you sort of puts you back to a point where now I can start working on my depression? Because
we always want to treat to remission. So the answer is yes. So the FDA approval is 36 treatments. Sometimes people need more, but yes, that's why it's FDA approved for the 36, is that we know that this is the amount that people will need in order to make the outcome, the efficacious outcome appear in their lives, right? Again, we're learning that the maintenance protocols are different for everybody. And we really go, we work with the patient in terms of how they're feeling, utilizing the PHQ-9 and other diagnostics. So depending on what the patient, what their diagnoses are, depends on, kind of how we go at that. And like I said, 30% of patients will need a tune-up. But some of our patients we never hear from again, right? If you go to our Facebook page and you look at some of the comments, and there, you can see that we have to combat certain things like how much it is, and what it's not. It is not shock therapy. We're using magnets, electromagnetic current. We have current in our body all the time, and so we're using the focality of the treatment to help our brain.
Oh, okay. I'm interested for a family member, and
Yeah.
they're on the spectrum. They have ADHD.
Mhm.
They have major depression. They're just all these things going on
Mhm.
in their life.
Yeah.
Self-medicating with, alcohol, the whole gamut.
Yep.
Trying all different kinds of medications. So like, where do you start? Like, do you attack a certain thing at one at a time, or do you just hit them all at once, or?
Yeah. I mean, again, this would be something that, that your family member would need to talk to the clinicians about. That's kind of more of a clinical question, but, we do a very holistic purview at what is going on. And ultimately the most dysfunctional, like what is it going to take for this patient to be functional, right? And then we look at, okay, now let's maybe look at how we can make them feel and cope better, right? It's kind of a, I mean, the psychiatrists know better than I do how to speak to that, because I don't even know, the patient's history and all of that. But to answer your question, it's a holistic scenario where we know that if we stimulate this part of the brain, it's going to affect their mood. It's going to affect their resilience. It's going to affect their outlook. We know that if you stimulate this part of the brain, it's going to make them less anxious. It's going to make them this, and again, we don't know if self-medication is happening because of the anxiety as a result of the depression, or as a result of the ADHD and or autism, or what have you. So there are universal treatments for multiple diagnoses.
Okay, great. Thank you so much.
You bet. Well, is that all you got for me, guys?
Well, if you're feeling good, we can certainly wrap up. Looks like we're 3 minutes over the hour. So
Yeah, no problem. I just want to thank you again for letting me share this. And you have my email. I'm happy to answer any questions as it relates to my personal patient experience and or the process in general. So please feel free. I truly do welcome any communication.
yeah, thank you so much, Carrie, for being here tonight. It's been so cool to hear about this treatment. I know I had never heard of this treatment before getting into contact with you. So thank you so much.
You're not alone. I mean, most of the mental health providers that I do presentations, it's a blip in their academia, right?
Mhm.
So we can all educate each other. So I applaud all of you for spending the evening with me.
Absolutely. Well, thanks everyone for joining us tonight. Again, this is a monthly educational forum sponsored by Evergreen Health. We do hold these every fourth Tuesday at 7 p.m. So next month's will be, I believe it's April 23rd. So keep an eye out for that. But otherwise, I just put in the chat a survey that you can fill out for us that just gives us some feedback to make more improvements to these kinds of things going forward, and give us some demographic information about who's coming to our programs. So if you have the time to fill that out, I'd be very grateful. It'll also redirect you to that after you exit the Zoom. But otherwise, thank you all for being here, and thank you for bringing your questions. And I hope you all have a wonderful evening.
Thanks.
Thank you so much.